Hello, everyone, both virtual and in person. We really appreciate those of you who made the trek to HSW to join us in person today, because we are very fortunate and to be doing a clinical problem-solving case today with Dr. Sarah Goglin. Dr. Sarah Goglin is an associate professor. Are you associate? Good. Associate professor in the Department of Medicine in the Division of Rheumatology. Her specializes in vasculitis and antiphospholipid syndrome, some of the most fascinating areas of rheumatology, and practices both at ZSFG, and we're lucky enough to have her at the UCSF Vasculitis Clinic as well. She has numerous leadership roles, especially in medical education, where she's the Associate Program Director of not only the Rheumatology Fellowship, as well as our Internal Medicine Residency Program as well. She's also the Associate Chief of Education for the Division of Rheumatology. So we're thrilled to have her as a discussant today. So Sarah, if you will join us at the podium, in front of the slides, that would be great.
Hi, everybody.
Excellent. So we are going to get started. Please feel free, if those of you in the room have a question you want to ask, please feel free to interrupt me and ask it. We want to make this as interactive as possible. We also do ask, though, that no spoilers in the chat if you think what's going on. Dr. Goglin won't see them, but other participants who may be following along and want to test their own diagnostic reasoning skills can do so as well. So other ground rules. Dr. Goglin does not know anything about this case, so she will be doing it blind, just as all of you will. And this is a journey, and we will follow this journey with Dr. Goglin and learn from her as we do, both learn her clinical reasoning skills and any pearls she wants to teach us about how she thinks as a diagnostician. And this is going to be fun. So be participatory, try and figure this out for yourself without Google as you listen to the case. Great. So Dr. Goglin, this is a 31-year-old woman. She doesn't have any past medical history. Love that. Always makes it nicer. Great. And she presented to urgent care with 1 week of a rash. You can see the picture of the rash here or on the screen. It started on her left thigh and then progressed on her legs, buttock, and back. Or her legs, chest, and back. Flat, red, non-painful, not itching, and it comes and goes. She couldn't find any aggravating or alleviating triggers, and she was presumed to have a viral exanthem, was given a prednisone taper. She had some mild improvement in her symptoms. So we would love you to talk about initial thoughts really regarding this rash, and if you could broaden it. We are often going to be in internal medicine. Rash will be the heralding symptom that we will find. And so broadening it a little bit and thinking about, well, what are red flags when you evaluate a rash, and what are some rashes you don't want to miss? And then if you could spend a little bit of time on how the response to steroids informs your differential.
Sounds great. Well, thank you all for being here and being on Zoom and for having me. I was talking to Beauty right beforehand and saying that I am nervous about this. So it's not just the trainees in the room that get nervous when having to discuss a case that they don't know exactly what's going on. So I'm excited to be here and to learn together. So rash is obviously a really common presenting sign and symptom of a whole host of different diseases and different groups of diseases. So my initial thoughts when I am approaching a patient in general with a rash, and then more specifically this patient that we're going to talk about today, are what is the morphology of the rash? What is the distribution on the body? How long has the rash been going on? And then thinking about, are there any other extracutaneous signs or symptoms that I need to pay attention to that may help us hone in on a more specific diagnosis or systemic etiology for the rash that a patient's presenting with. I think here, just going back to some specifics in this case, first of all, this patient at this point has only had the rash for a week. So when I think about this with my rheumatologist hat on, rheumatologic causes are actually very low on the differential still, because we're still in an acute time frame. And there are many things, infection being one of them, allergic reactions being another, that are much more common in terms of their base rate of disease causing rash. And I wouldn't yet be thinking about kind of more esoteric causes in which I would kind of group most of rheumatology in that relatively esoteric category. And the things that I notice here are that it's flat, which helps me as I think about morphologies and different types of rashes that we'll talk about more, and that it's not painful and it's not itchy. And so I think the presumption that this could be a viral exanthem was a very reasonable one to have up front. In terms of red flag symptoms that I look for when I'm assessing a patient for a rash, the first thing is actually thinking outside of the skin. So does the patient have a fever? Do they have signs of systemic inflammation with hypotension or tachycardia? If we have lab values, are there clues there with elevated liver function tests, for example, or eosinophilia that might make us think that we need to think about severe systemic reactions such as a drug reaction or getting into either rheumatologic or malignant causes of rashes. The other would be assessing the rash itself, so looking for mucosal involvement that might make us worried about a serious drug reaction in particular. Are there like bullous lesions that are present or really severe kind of areas of necrosis that might make me think about different types of infections or inflammatory conditions at play. And then the final question, how does the response to prednisone kind of inform how I'm thinking about the case so far? It doesn't really inform it much at all. There are lots of things that get better with prednisone, including infectious rashes, which have an inflammatory component to them. So it doesn't really help me as I try to narrow in. And at this point, the differential is still very broad for what might be going on with this patient.
Thank you. All right, so 2 weeks later, she presents to the ED. Her illness has progressed. She still has an ongoing rash, but she now has 2 weeks of joint pain. It makes it difficult to get out of bed. She took the steroid taper. It was a 10-day taper. She had minimal improvement in her joint symptoms, but now feels like they're getting worse. So a little bit about her joint pain. It started in her bilateral knees, progressed to hands and wrists. It's intermittent. It lasts for hours and sometimes spans the full day, and it comes on every day. She's still having fevers daily. She has myalgias as well as the joint pain. Those come and go daily. And she had an MMR vaccine 3 days before her symptom onset. So her meds, only notable for ibuprofen, no allergies, no surgical history, family history of breast cancer in her mother, born overseas in New Delhi, India. She visited 8 months ago, but has been a resident of SF for 3 years. Married, no pets, works as a program manager, monogamous with her husband, and no alcohol, tobacco, or drug use. So we now have more information. The plot thickens, and my temptation when I read this is I was like, oh, joint pains and fever. Let me narrow my differential. But I'm sure you, as a rheumatologist, are very skilled in keeping that differential really broad, since we general internists tend to be like, oh, that's got to be rheum. Yeah. So if you could help us keep that differential broad, and then this MMR vaccine, help me out. How might that be playing into it?
So maybe could we just go back to the slides for the initial, so this is helpful here. So things are definitely starting to get more interesting, right? So we talked before about the rash was very acute, but now 2 weeks later, she's still having rash and she's developed this new symptom of, it sounds like really significant joint pain and impacting her functional status. So my concern for, a non self-limited viral illness as the cause of that rash has now gone way down. And I start to worry about systemic illnesses that are in the more subacute to chronic phase that could be presenting. And, when I evaluate patients that have rash and what sounds like probably inflammatory joint pain, that differential is still broad. I'll kind of leave the rheumatologic diseases for the last part, because I always try to think first about, could this be an infection? Could this be a malignancy? And then I really think about the things that I know the most about as a rheumatologist. So could this be an infectious process? It definitely could. I mean, you can develop inflammatory arthritis with all sorts of infections. Viral is probably the most common thing that we think about, and specifically parvovirus infection, if she has had exposure to small children. The time course now, though, that this is still going on an additional 2 weeks later makes that a bit less likely, because in most cases, patients will start to have felt better rather than have an escalating kind of tempo and progression 2 to 3 weeks in. Other infections though, so hepatitis B can also present in this way, and it's also in kind of the subacute phase of infection with Hep B, so would be curious to know her vaccination status, as well as her hepatitis B serologies. I noted that she is from India, so thinking about are there infections that she could have been exposed to there that are now presenting in this way here? Probably not. Tuberculosis can cause different sorts of cutaneous manifestations and articular manifestations, but the rash that she's presenting with doesn't concern me for a rash related to TB or thinking about fungal infections either. And it also doesn't seem consistent with a kind of a severe acute bacterial infection. So if this were infection, I would be thinking viral. But again, for the reasons I mentioned, a bit lower. Then thinking about, could this be a malignancy? So especially in a person who is in her 30s, thinking about hematologic malignancies, which can really present with many different types of rashes, as well as inflammatory arthritis. So I'll be curious to know that a good lymph node exam was done, looking closely at her CBC and peripheral smear, thinking, are there other signs that might be going on? And then from a rheumatologic standpoint, what do I think about? So based on her age, I would certainly consider a diagnosis of systemic lupus. Now, this rash is not a classic rash for lupus, but lupus can have cutaneous manifestations that don't cause lupus-specific rashes. So definitely a possibility. This doesn't seem consistent with a presentation of rheumatoid arthritis based on the skin rash alone, but could explain the joint symptoms that she's presenting with. So I also think about, could she have two things going on at the same time? Thinking about the big bucket of systemic vasculitis, so systemic vasculitis can present with inflammatory arthritis, often kind of a migratory arthritis affecting medium-sized joints. So possible, but the rash that I'm seeing is not a vasculitic looking rash. She doesn't have palpable purpura, for example, so that would be lower. And then I'd be thinking about like really rare things like adult onset Still's disease. I mean, we think about it all the time in the hospital, right? And I would say as a rheumatologist, it's kind of our feared consult question because so many things need to be excluded before we can really narrow in on that diagnosis. But in this patient who's having daily fevers, who's having this intermittent evanescent, kind of pink salmon colored rash, and then inflammatory joint pain, it definitely would be something I would think about. The MMR vaccine. So is it 3 days before the rash started, or is it 3 days before the joint pain started? Do we know?
3 days before the rash.
Before the rash. So you certainly can get, arthralgias, myalgias, and rashes in reaction to vaccine. I wouldn't expect it to be still going on, though, 3 weeks later from a vaccination. So I think it's probably not related.
Excellent. I'm learning so much. Yes, Dr. Najafi.
Yeah. 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 Yeah.
Could you give us some advice so that we don't fall into the trap of being like, oh, yeah, they had a cold and they had a GI bug, and maybe that's what it is?
Yeah, so I'll just repeat the question for everybody on Zoom, kind of trying to think about what helps us be more specific about a patient when they're coming in with joint pain. When is it okay to kind of chalk it up to a viral illness? When do we need to think about reactive arthritis or something that's like non-infectious altogether? So, common for people to have arthralgias with a viral infection, much less common to have true inflammatory arthritis though. So if someone has like frank joint swelling that you can appreciate on exam, especially if it's persistent beyond like 4 weeks or so after their viral illness, if that had been identified, it starts to become much more concerning for an unrelated rheumatologic process. Reactive arthritis tends to occur after, GI or GU illnesses. I would say in a lot of patients, though, they don't ever have an antecedent infection that's identified. So for us, it's really helpful to know the pattern of the arthritis because reactive arthritis tends to cause this very inflammatory lower extremity predominant. So it's like the patient coming into the ED with a big swollen knee and maybe an ankle too. If you tap the fluid, it's like 80,000 whites. That's the typical picture of reactive arthritis. So I would say it's the pattern and it's the time course of the arthritis that are really helpful to us when we're seeing patients and trying to flesh this out. But sometimes it's just a matter of time to see if this something just goes away on its own over the next few weeks, or is it persisting and getting worse? And that tincture of time helps us in many cases.
Excellent, thank you. So she presents again to care, her vital signs, normal blood pressure, tachycardic. You could see all of her vitals there. I'll just go over the significant physical exam points. She does have tender cervical lymphadenopathy. She is tachycardic. She still persistently has this rash with flat blanching erythema on her cheeks and sparing her nasolabial folds, on her thighs, her left forearm, and foot. She has mild synovitis on her bilateral elbows, shoulders, tenderness to palpation of her lateral elbows, AC joints as well, and she's tired of caring but has no focal deficits. Her laboratory evaluation, helpful results in blue. She has a mild leukocytosis with a left shift, otherwise normal. Her chem panel is normal. She does have some transaminitis and an elevated alk phos. You can see her normal ABG here. Total protein is 10, albumin 3.9. She's not pregnant. ESR is 7, CRP is 129, ferritin is 182. Her UA is bland and her TSH is normal. So taking some of those abnormal highlights, would love your big picture, and I'll flip back to the labs and the physical exam as needed. But the questions we are hoping you can touch on is thinking about this lymphadenopathy. Does that help you at all in your differential? And the abnormal LFTs that sort of can partner with a lot of things you've already mentioned, and linking that back to your differential would be really helpful. And lastly, next diagnostic and therapeutics steps. So I'll go back to this.
Okay, maybe we'll go back to the exam first
sure.
and talk about the lymphadenopathy. So, the lymphadenopathy is obviously not specific and can occur in every condition that I've mentioned so far, at least in the big buckets that I've mentioned. So I would still be thinking about the possibility of a lymphoma in this patient, and knowing that she has cervical lymphadenopathy would make me consider that a bit more, although her CBC is reassuring. And the fact that she doesn't have more diffuse lymphadenopathy also somewhat reassuring. We definitely see lymphadenopathy in some, although not all, of our rheumatologic diseases. So I mentioned lupus before. I'll mention again, especially with this rash that's on her face that spares the nasolabial folds, which is really a classic feature of malar rashes of lupus. So patients with lupus can get localized or diffuse systemic lymphadenopathy, either specifically as part of lupus itself, or sometimes they have kind of overlap with something called Kikuchi-Fujimoto disease, where they get a necrotizing lymphadenitis that happens. And so that has a predilection for the cervical nodes. And so I would think about that here. And then obviously infections of all kinds can cause lymphadenopathy, but I don't typically think about the viral infections, especially like thinking about Hep B in this patient as a big cause of cervical lymphadenopathy. So I think, again, still very broad in terms of how I'm thinking about the patient, and that lymphadenopathy is not a specific enough finding for me to narrow based just on that. I'll just comment again on the rash. So I'm not sure if we'll be able to see a picture of that rash on her face or not, but when I see that comment that it spares the nasolabial folds, my suspicion that this facial rash could be a manifestation of cutaneous lupus goes up. So other facial rashes that are erythematous on the face, for some reason, don't spare the nasolabial folds in the way that lupus often does. So that's something we always look for to help us understand if a facial rash could be related to lupus or not. It's not, again, specific enough to make that diagnosis all by itself, but maybe raises lupus a bit higher just based on this exam. And then, she does have inflammatory arthritis based on this exam, which is consistent with everything we've heard so far. And then the labs. Okay, so just a couple of things that I noticed. She has this leukocytosis, and as I think about the possibility of could this patient have lupus, this stands out as something that doesn't fit with my illness script for lupus. So lupus patients tend to have leukopenia and specifically lymphopenia, and that tends to worsen when they are in flare. It's not a hard and fast rule though, so it doesn't rule out lupus, but it's just something that I pay attention to. And also the fact that her platelet count is so normal, again, it doesn't exclude the possibility of lupus, but it doesn't raise my suspicion for lupus as high as if this showed thrombocytopenia. Her diff, it sounds like, she has a neutrophil predominant differential, but no other concerning findings in that diff. And I'd be curious, I'm sure she got a smear at some point, but that would be part of my next workup. Again, just thinking about hematologic malignancies and the different ways that they can present. Looking at her inflammatory markers, there's this interesting disconnect here between the sed rate and the C-reactive protein. And I am not quite sure how to explain that at this point in time. There are some conditions where the sed rate can be artificially low. So sometimes we'll see it drop precipitously, for example, in patients with Still's disease, but her ferritin is really low too. So that doesn't really fit with Still's disease, where we would expect the ferritin to be quite elevated into the thousands. So the C-reactive protein tells me she has a lot of inflammation. It doesn't tell me anything more than that. Again, going back to this question of lupus, in lupus, we tend to see high ESRs and normal CRPs, except in some specific exceptions to that. People with like mesenteric vasculitis or really severe serositis, which it doesn't sound like she has. Her urinalysis is very reassuring to me. I don't see any. So the other thing I do when I'm assessing a patient and thinking about could there be other organ involvement, the kidneys are often affected in many of our diseases in rheumatology. So I always look at the UA, and there's nothing concerning here in terms of hematuria, and I'm assuming no proteinuria since it wasn't commented on. So no signs so far of a glomerular process that could kind of help us tie together or help us look for a place to get tissue. And then she has this elevated total protein. And so there's an elevated protein gap there. Again, thinking about could she have a monoclonal gammopathy of some kind? Could she have hypergammaglobulinemia related to an autoimmune disease? So it's something I noticed, but again, not specific enough to hone in. And then the LFT abnormalities, also non-specific so far, right? So we see abnormal LFTs in all different states of inflammation. So it doesn't really help me. I think we talked about potential for infection. Viral infection certainly could cause this picture. Rheumatologic diseases, lupus, adult onset Still's, others could cause this picture. And also I would imagine that in hematologic malignancies, you might see this too.
I'm going to move us along,
Yeah.
but I do want to get your initial thoughts on like, what do you want to do? What are the most important management steps that you want done for her as she's admitted?
Yeah, so I think in terms of next steps in diagnostic workup, it would be really helpful to have dermatology see her and help us think through this rash. Is there a target there that could be biopsiable that would allow us to be more specific about what the cause of the rash is? I can certainly think about other rheumatologic serologies that we would send at this patient, in this patient. So certainly would be very reasonable to check an ANA. I am not seeing anything here that makes me worried about ANCA-associated vasculitis, so wouldn't check an ANCA. I would check complement levels, again, thinking about ANA positive diseases that are often associated with hypocomplementemia. Kind of depending on how things go with the skin evaluation, a lymph node biopsy may be in her future, but I wouldn't jump to that quite yet because we may be able to make this diagnosis without needing to do something more invasive like that. I wouldn't recommend antibiotics for this patient based on what I'm seeing. I wouldn't start her on empiric immunosuppression for rheum disease NOS. I think there's just still a lot of diagnostic uncertainty here. And she's stable, so we have time to work through our diagnostic steps before jumping to therapy.
I really applaud you for your parsimonious approach. And this is what happens when you have like someone who has such great clinical expertise that they can really navigate the sea of options, both diagnostic and therapeutic options.
The sea of autoantibodies. I
Yes,
hope they will.
exactly. So the patient was admitted with concern for sepsis and started on broad spectrum antibiotics.
This is why I'm not a hospitalist, because I don't know when you're
There-
supposed to start
there was
people on antibiotics.
High fevers, leukocytosis, it's hard,
Yeah.
man, it's hard. A broad infectious and autoimmune workup were sent. She also received CT scans. So she did have enlarged bilateral level 2A cervical lymph nodes, but no mediastinal lymphadenopathy, no lung findings, and no organomegaly or lymphadenopathy in the abdomen. Antibiotics were stopped on hospital day 3, very appropriate. And here is an update on her labs. Her leukocytosis is resolved. She is anemic. She's becoming thrombocytopenic. Her LFTs are persistently abnormal. I think her alk phos is a slight improvement, but not. Her D-dimer is elevated. Her haptoglobin is now quite elevated. Her ferritin has now become quite elevated. Smear that you had asked for is normal, INR normal, fibrinogen normal. And you can see her fever curve plotted out there with significant ongoing fevers.
Okay.
So here are some additional
Just
labs
review.
just to help you out. I think these are largely negative. I'm not going to read them all out, although you can see that CRP has gone even higher, and then the ESR is now elevated as well. And then normal complement levels, which I think you had wanted, ANA negative. And they did send some ANCA studies, which were all negative as well. So, and got a TTE.
Okay.
Great. So we'll turn to our audience. You get to judge what you think the next step in this patient's management would be. Oh, let's do it as a show of hands here so that you all get to participate as well. So folks in the room, while the Zoom folks are going, folks in the room, what would you do next? We're going to do a show of hands. I'll read all the things and then I'll show of hands for each one. Would you A, restart broad spectrum antibiotics, B, do a skin biopsy, C, do a lymph node biopsy, or D, start steroids? Oh, wait, I was just reading.
The rheumatologists are all like,
So how many of you would restart broad spectrum antibiotics? All right, very good. How many of you would do a skin biopsy? Okay, some for skin biopsy. How many of you would do a lymph node biopsy? Lovely. And how many of you would start steroids? Yeah, the temptation to start steroids is really high.
I know.
I'm really
Sometimes we gotta
proud
hold
of
you back.
y'all for exercising your restraint. Excellent. So, oh, sorry. Audience response. Anna, take it away.
I'll read from what folks have been saying online. So it looks like most people are interested in a lymph node biopsy. 58% of people and 34% want a skin biopsy, and a few people want to start steroids. Nobody wants to start antibiotics.
I love it. I live in fear in these things of like advancing the slide too quickly at the wrong moment. I'm glad I did it then. Hopefully then I won't do it at the final slide. So the team obtained an excisional lymph node biopsy, which showed reactive features. Flow cytometry showed no abnormal lymphoid population. There were many immunoblasts, suggesting that it was a very activated lymph node. Hospital day 9, the patient becomes tachycardic, hypotensive, hypoxemic, requiring supplemental oxygen. Labs are demonstrating worsening cytopenias and rising LFTs. A VBG is seen there. pH is 7.32, but PCO2 is 48, and her lactate is still normal at 1.8. So we'll go back to the audience. I'll do this one better this time. Anna, if you could launch the poll, that would be lovely. And then folks in the room, since you all were so eager to raise your hands, we'll do it the quick way, which is read the things. So what is your next step in initial management? How many of you want to give more fluids and continue to hold off on the antibiotics? How many of you want to start pressors? How many of you want a CTPE? How many of you want to give fluids and start antibiotics? And how many of you want antibiotics and you want antifungal coverage? All right.
There's almost an even split online.
Between
Basically
fluids and
20%,
antibiotics and fluids and-
20% across the board almost. Maybe a little bit of like preference for fluids and antibiotics alone.
Excellent. Well, the team, recent cultures They were like, let's just make sure that there's not a PE involved in case there's a hypocoagulable state going on. Hypotension did improve after fluid resuscitation, and the patient was restarted on broad spectrum antibiotics with cefepime and vancomycin. So, Dr. Goglin, we'll turn it back to you. Now, at this point, you have watched this patient over time, and I'm curious if you had to rank your differential at this point in the case, what would it be?
Yeah, maybe can you go back to the left,
Yes.
please, Michelle? So
Do you want this one or the other one?
probably
This one's
this one's fine. Yeah. So obviously this patient is becoming a lot sicker, and the very broad infectious workup to date has been totally unremarkable, right? So my suspicion for a non-infectious inflammatory disease is like, you know, number one on the list. And I realize that's a broad category. I'll be more specific. I loved the split in the room. I noticed all the rheumatologists voted for a lymph node biopsy, and the hematology oncologist voted for a skin biopsy. So I will just say, I think, you know, a lymph node biopsy for us was important, I imagine, in this case, because we really need to exclude malignancy as a cause of what this patient is presenting with. It would probably still be in like my top 3 to 5 concerns, but I am cautiously reassured by the negative workup so far, as well as, you know, getting expertise from our oncology colleagues that this is really not consistent so far with them, something like a lymphoma, and the, you know, the imaging showing no other areas of lymphadenopathy, also reassuring from that standpoint. So I am worried that this patient is developing macrophage activation syndrome, right? So she has really precipitous drop in all of her cell lines, worsening LFTs, and significant signs of hemodynamic instability. It could be related to adult onset Still's disease, which is known to be a trigger of macrophage activation syndrome. And we still kind of need to hone in a bit more on her rash, but although it's a super rare diagnosis, that would be kind of the top of what I would be considering in this patient right now, because the teams have done a great job of excluding other potential causes. There are other viral infections that she hasn't been tested for yet that can also be triggers of MAS. So I'm sure, you know, ID would remain engaged with the care of this patient, but thinking about, okay, is it time to send kind of a more extensive serologic workup for viruses to make sure that one of those is not identified as the cause of this presentation? And then I'll say, like, lupus is really off the table now. So lupus is also a potential cause of MAS, but her ANA is negative, the subserologies are all negative, her complements are normal. So I feel confident that we have excluded that as a possible cause. So I don't know that I have 3 things really on my list right now, but it's MAS broadly, potentially from adult onset Still's, potentially from a yet to be identified viral infection, and then like a distant third, could she just have a malignancy that we haven't yet identified, causing this presentation of cytokine storm?
Great. I had a question about the lymph node biopsy. Does that, how necessary is that to really rule out malignancy? Is that part of, should people think of that as part of the workup in really saying that this is a rheumatologic disease?
So you probably get conflicting answers depending on who you talk to. But from my standpoint as a rheumatologist, I would say that especially when it comes to adult onset Still's, that is such a rare condition, and there are so many things that can mimic it, and we're thinking about committing a person to significant immunosuppression, that we, in almost all cases, advocate for a lymph node biopsy for those patients, because we have all cared for patients in whom we've been surprised by what has been found. We don't need to do lymph node biopsies in everyone, though, in whom we're considering a rheumatologic disease. So for lupus, for example, if I was convinced the patient had lupus and they had lymphadenopathy, if the features were overall benign, I wouldn't put that patient through a biopsy unless things were progressing in an unexpected way.
Great, that's really helpful. Yeah, Sam,
Yeah,
I was actually going to ask you if you had any input. Can we give Sam the microphone?
Oh, hi. I always love conversations between rheumatologists and hematologists around like the rheumatologic versus malignancy, different possibilities. And I'm so curious in terms of the pancytopenia in a sick patient with multi-organ dysfunction from the rheumatologic perspective. What's the thought about a primary bone marrow issue versus this being more likely a secondary kind of marrow suppression from an inflammatory condition?
If I'm understanding your question correctly, so do you mean a primary bone marrow issue from a rheumatologic disease?
Oh, sorry.
Or?
I was really unclear. I
No, no,
meant
no.
like a acute leukemia
Oh, acute
as a
leukemia.
possibility.
Yeah, well, I would probably ask you that question. I think here, the being able to follow her clinical course over time seems to be helpful to me, given how relatively normal her CBC was when she came in, except for that leukocytosis, and then this very acute drop with a normal smear. And an otherwise like unrevealing diff. My suspicion for acute leukemia is not high at this point in time, but I would turn to the people that have a whole lot more experience with acute leukemia than I do to make sure we don't need to, for example, do a bone marrow biopsy in this patient or be thinking about other diagnostics. And probably a bone marrow biopsy is in her future, if I had to guess, as another diagnostic test, just to be sure that we're not missing a malignancy in this young patient before we, start her on 60 of prednisone for presumed adult onset Stills transforming to macrophage activation.
Great. Excellent. So here are some additional diagnostic testing to help. This is the last hone your differential slide. Could you, is there anything else you need before we ask you for a diagnosis? So here you go. There's some NK cell activity that's quite low that might be helpful. IL-2 receptor antibody that's elevated. You did get a bone marrow biopsy, just as you said. Make sure to rule out hematologic malignancies, which was normal, no atypical lymphoid infiltrate that was seen, and normal cellular. So, do you have a guess at a final diagnosis?
My guess is that she has macrophage activation syndrome, or HLH, depending on how you want to call it, secondary to adult onset Still's disease.
And brilliant. And what I loved most about that was not the final right answer, but just taking us through your amazing differential and
Thank you.
Really keeping it broad and helping us shed light on how a master clinician does diagnostic reasoning. So thank you.
Yeah, of course. Thank you all. And thanks for picking the most common disease we see as rheumatologists, right?
Yeah. So we are fortunate enough to have two in-person expert discussants. I'm going to introduce first, a little bit of clinical course. Patient was started on dexamethasone and anakinra, I can never say that. Her rash and fevers both resolved, her inflammatory markers and her cytopenias improved. She was discharged from the hospital after a 3-week admission. As an outpatient, she's following up with rheumatology and tapering off steroids. She did develop injection site reactions, and it was transitioned to another biologic. And she's had stable labs now for over a year. She's would love to taper off all of her medications, and so potentially that is in her future. Before we pass it on to our expert discussions, I want to give a huge thank you to our two chief residents, Viri and Anna, for preparing this case so thoughtfully and thoroughly. And we are going to turn it over to Dr. Vivek Murphy, and who will take the podium.
Hi, everyone. I'm really excited to be here with you today. And I just wanted to say it's been so fun to watch Dr. Coughlin's expert reasoning. It's something that myself and the other rheumatology fellows in the room get to witness on a weekly basis. So it's really awesome. I think when I was invited to attend today, I spent some time thinking, what are some high-yield teaching points about Stills, and could I fit them onto one slide? I think the answer to that is unfortunately no, but here's my attempt. The first thing to know is that Still's disease is an idiopathic multi-system inflammatory disorder, and it was first described in the late 1800s by George Still, who was an English pediatrician who wrote case series of pediatric patients who had this shared constellation of rheumatic symptoms: fevers, arthritis, rash, pharyngitis, and some of them also had serositis. What we know now is that he was describing pediatric systemic JIA and its analog in adults that we call Still's disease. Second thing to know that Dr. Coughlin hinted at is that this is extraordinarily rare. I think we talk about it an order of magnitude more than we actually diagnose it. And to give you some sense, in international epidemiologic studies in various cohorts of patients with Still's disease, the incidence has been calculated at 0.1 to 0.4 cases per 100,000 people annually. To put that into context, if you average these incidence rates and multiply them by the population of the US in 2020, which was 329.5 million, that would predict 824 cases of Still's diagnosed in the US that year. That's a low number. So indeed, this is thought to be quite an uncommon condition. Third thing to know is the cardinal manifestations of Still's are high fevers, characteristic rash, and arthritis. Each of these manifestations individually is present in between 75 to 95% of patients. So it's this triad that should really prompt us to think about Still's in our differential diagnosis, in addition to the other things that Dr. Goglin outlined. In terms of natural history, patients with Still's assort into thirds in terms of their natural histories and their disease trajectories. The first third have monophasic illnesses. That's exactly what it sounds like. Patients have a short bout of self-limited Still's disease, which can last for weeks to months, is treated, treatments are tapered off, and by the end of a year, the Still's is gone, never to be heard from again. A second third of patients have what's called intermittent disease, and that's also exactly what it sounds like. They have intermittent disease flares, which are punctuated by periods of remission. And as the disease goes on, as time goes on, the disease attenuates in severity and duration of flares. And the final third of patients has chronic disease, unfortunately. This is persistent, unrelenting Still's disease that often requires first-line, second-line therapy, lots of steroids and steroid morbidity, and a destructive deforming arthritis, particularly of the wrists, is characteristic in this population. Fifth, I wish we had a lab test for Still's. I wish there was a stain on pathology that would tell us a patient had Still's. That would make our lives a lot easier. But unfortunately, it's a clinical diagnosis of exclusion. Signs and symptoms supported by compatible lab abnormalities, and also certain diagnostic criteria, which I'll talk about. And in terms of treatment, your treatment options are NSAIDs, which we use first line in mild disease, and it's sufficient to treat about 20% of patients, but the remainder require moderate to high dose steroids coupled with a DMARD, which is far more often. So I know that many of you are already familiar with a lot of the clinical manifestations of Still's, but I just wanted to review some of them to contribute perhaps a little bit more nuance. We often hear of the fever in Still's being quotidian, which means daily. I think we use the term quotidian because otherwise we'd never have an opportunity to actually use that word. But the truth is that fever in Still's is a little bit more complicated than it's taught. In 20% of cases, these patterns don't really apply. The fever can be biquotidian, twice a day. It doesn't necessarily have to be regular day to day. It can show up at different times of day. Some patients, like this one, had a hectic fever course, and it's very hard to find periods of time during the day where they're actually afebrile. So all this to say, there's heterogeneity in the fever patterns of Still's, and you can't really rely on the quotidian fever as helping you make the diagnosis. The rash, these are pictures from this patient. As Dr. Goglin pointed out, is non-pruritic, evanescent, salmon-colored, macular, or maculopapular. These are all kind of like an adjective soup that have been used to describe the Still's rash. Other things to know are that it's most commonly found on the torso or the limbs, but you can sometimes find it on the palms, the soles, and even on the face. It tends to synchronize temporally with the fevers. And the other thing to know about Still's rashes are you may see the Koebner phenomenon. So that's instigating a dermatosis that's known through trauma. And it might be as light as simply stroking the skin as someone has a fever to elicit this rash. And you also have to make sure that when someone's febrile and you're entertaining a diagnosis of Still's, that you really do a full body skin exam, especially parts of the body that are impacted by pressure from clothes, like the belt line, because that could sometimes be the only place that you see the rash that helps guide you towards the diagnosis. Soft tissue manifestations, many patients report myalgias. These are typically mild and the CK is normal, but some patients report a really debilitating experience of myalgias where they're bedbound and they can't get up and walk because of it. Oligoarthritis and arthralgias are really common, seen in 75 to 95% of patients. The arthritis, as I mentioned, is most often an oligoarthritis, meaning 2 to 4 joints affected. And there's really a predilection for the medium-sized joints, which are listed here. In terms of sore throat, 70% of patients have a mild, moderate, or severe sore throat, and it's often act 1 in the play. So this can precede a lot of the articular manifestations, the soft tissue manifestations, the rash, all the rest of it, which can lead to some confusion with a viral URI or a viral xanthem. And they've actually done MRI studies of necks in patients who have Still's disease, and it shows that there's a lot of different structures that can be affected to produce the sore throat. It can be a non-suppurative pharyngitis. You can also get cricoarytenoid arthritis or cricothyroid perichondritis. There can be inflammation of a few structures that produce this characteristic symptom. To make it even more confusing, 2/3 of patients who have Still's have pathologic lymphadenopathy, often mistaken early for lymphoma. The most common site to have lymphadenopathy is the cervical regions, and the lymphadenopathy is usually mildly enlarged, bilateral, symmetric. But there are exceptions to every rule, which I feel like should be the caption to all of rheumatology. In that you can get asymmetric lymphadenopathy, you can get multifocal lymphadenopathy, really bulky lymphadenopathy has been described. So there's exceptions to quite literally every rule. 30 to 50% have an enlarged spleen, 10 to 40% have an enlarged liver, contributing even more confusion and kind of early diagnostic way towards a hematologic malignancy, rightfully so. Other manifestations in Still's have been reported. These are less specific, and they won't really help you if you're really trying to generate evidence that this patient has Still's, but they're compatible and well described, so they're important to know about. In the interest of time, I won't go into each of these, but suffice to say that HLH in many, many case series in the literature is seen in 10 to 20% of patients in those case series. So it happens a lot more often in Still's than one might think. So it's important to have an index of suspicion for it. In terms of lab abnormalities, virtually all patients have elevated inflammatory markers, often above the upper limit of detection. CBC abnormalities that are characteristic are included here. I won't read them, but neutrophilic leukocytosis is part of diagnostic criteria, which we'll talk about. The ferritin is often elevated. Many of you know that ferritin is an acute phase reactant, which is produced by hepatocytes under influence of circulating cytokines. And it's often elevated more than 5 times the upper limit of normal, which is 1,000. But we very commonly see patients have a ferritin value in the several thousands or 10,000 and even above, especially if their illness is complicated by MAS. LFT abnormalities and LDH elevations are seen in 3/4 of patients in many case series. And to make things even more confusing, in fewer than 10% of cases, the ANA and the RF can be positive. But when they are positive, they're usually positive in low titer, and there aren't any signs or symptoms that are more specific for the ANA-related conditions or the RF-associated rheumatologic conditions. As I mentioned, I wish we had a single test to help tell us that someone has Still's, but we don't yet have that. Instead, we have diagnostic criteria. Several sets have been proposed, but the Yamaguchi criteria are the most specific in several cohorts. To increase one's suspicion for a diagnosis of Still's, you really need 5 of these criteria, with at least 2 being major. And you need systematic exclusion of all other possible causes of systemic inflammation. What you'll see here are little X's, and those are to indicate which are relevant to this patient. So all but 1. And then finally, treatment. The goals of treatment in Still's are to reduce signs and symptoms of inflammation, recognize and manage any complications, prevent organs from having irreversible damage, and of course, minimizing treatment toxicity. And I'm thinking about steroids in particular when I say that. For patients with mild disease, meaning they just have fever, rash, and arthritis, NSAIDs at anti-inflammatory dosing may suffice. In fact, these are sufficient in about 20% of patients. But for the other 80% who have moderate to severe disease or NSAID refractory disease, and you can see some of those definitions here, we use moderate to high dose prednisone, optimistically tapered over 2 or 3 months, but the truth is sometimes steroids are needed for much longer, paired with a DMARD such as anakinra, which is an IL-1 receptor antagonist, or methotrexate, which is a tried and true anti-metabolite that we use a lot in rheumatology clinic. So I'll conclude there because I know we have more information to get to, but thanks for having me.
Thank you, Dr. Murphy. Thank you. That was some very excellent teaching. And now we're going to pass it over to our fabulous hematology and medical oncology fellow, Dr. Hua Lim, who's going to tell us about HLH and macrophage activation syndrome.
Thanks so much, Michelle. And thanks so much, Dr. Gofflin, for your masterful clinical thinking. You know, I feel like on the hemonc side, we're often co-consulted for a lot of very sick, mysterious patients here at Parnassus, together with rheumatology and infectious disease. So it's really fantastic to learn from you and from you, Vivek, about how to think about conditions like adult onset stills from a rheum perspective. And then thank you, Anna and Vidi, for putting this fantastic presentation together. So what I'm going to do in the few minutes we have left is walk you through macrophage activation syndrome, and also more broadly through hemophagocytic lymphohistiocytosis, or HLH, which is the broader syndrome that the macrophage activation syndrome is a part of. So what is HLH? You know, as many of you know, it's a rare condition, but one that we see not uncommonly on the hospital medicine service here at Parnassus. The way it's defined in the hemonc world, so this is the Histiocyte Society definition of HLH. They define HLH as an aberrant hyperinflammatory hyperferritinemic immune response syndrome that's associated with a potentially fatal cytokine storm. And again, macrophage activation syndrome is a subtype of HLH. Let me walk you quickly through the pathophysiology of this. So HLH involves macrophages, which are antigen-presenting cells. And when macrophages in the body encounter antigens, they become activated. Now, normally, activated macrophages are downregulated by natural killer cells and cytotoxic T lymphocytes. But the thinking is that in HLH, that downregulation becomes inhibited, such that excess macrophage activation occurs, and also NK cells and cytotoxic T lymphocytes become excessively activated. All of that excess immune cell activation leads to elevated cytokine levels. So that's a so-called cytokine storm that is often seen in HLH. And then that leads to a hyperinflammatory syndrome, which results in end organ damage. So there are two main subtypes of HLH. The first is primary HLH, which is an inherited disease. It's caused by inherited defects in genes that affect NK and T cell function and inflammasome regulation. This is pretty rare to see in adults. It mainly occurs in children and adolescents, so but quite rare to see in patients here at Parnassus. Rather, the more common flavor of HLH that's seen in adults is secondary HLH. In other words, HLH that's secondary to some underlying etiology. And the most common trigger of secondary HLH is malignancy, which is responsible for 40 to 70% of HLH in adults. The most common malignant culprit is lymphoma. In fact, HLH occurs in around 3% of all adult lymphoma patients. Leukemia and solid tumors, though, can also be HLH triggers. Infection is another common trigger of secondary HLH. We mainly see this in immunocompromised host viral infections, so the most common being EBV infection, but CMV, HIV, HHV8 viremias can all also trigger secondary HLH. Autoimmune diseases are, of course, a common trigger, and macrophage activation syndrome is a term that we use to define HLH that's secondary to an autoimmune process. CAR T cell therapies, as many of you know, are increasingly being used to treat patients with heme malignancies. And when that causes secondary HLH, we call that the cytokine release syndrome. And then finally, a variety of conditions that can cause hyperinflammation due to exposure to novel antigens can also trigger HLH. Those include pregnancy, transplantation, and trauma. So when should you suspect HLH, right? How do we diagnose this? Well, HLH is a sepsis mimicker. It's rare, but it's not unreasonable to suspect that HLH could be present in a patient who has sepsis physiology and meets some of the HLH diagnostic criteria, especially if a patient happens to be sick, right? So if HLH criteria are partially met and someone has sepsis physiology, almost always a reasonable heme consult. Now, the definition of HLH diagnosis is that it requires 5 out of 8 diagnostic criteria to be met that were studied in the HLH 2004 clinical trial. And these are fever, splenomegaly, cytopenias affecting 2 or 3 lineages, hyperferritinemia, high triglycerides or low fibrinogen, hemophagocytosis in bone marrow or other tissue, an elevated soluble IL-2 receptor level, and decreased NK selectivity. Like so many other things in internal medicine, there is a score that you can use to risk stratify patients where you're worried about HLH. This is called the H score, and the higher the H score, the more likely HLH is to be present. And fortunately, like so many other scores, it is available on MD-Calc, so you can always calculate this on your phone in a jiffy. Now, the patient we talked about today ended up ultimately meeting 6 of the 8 HLH diagnostic criteria, and also correspondingly had an H score of 235, which is quite high, corresponding to a 98 to 99% probability of HLH being present. So how do we treat HLH? Well, the treatment of secondary HLH, which again is the most common flavor of HLH in adults, mainly involves treating the underlying etiology. Because if you treat the trigger of HLH, the HLH itself is also likely to get better. So for instance, for HLH secondary to lymphoma, the mainstay of treatment is chemo. For HLH due to infection, you treat with antibiotics. And for a macrophage activation syndrome, i.e. HLH due to an autoimmune process, you treat with immunosuppression targeted at the autoimmune disorder, as was done in the patient we talked about today. In rare cases, though, in acutely deteriorating or very ill patients, then on the heme consult service, we sometimes will consider HLH-directed therapy. And the main HLH-directed therapies are dexamethasone and etoposide, which in the HLH-94 clinical trial were shown to confer survival benefit. So for heme consult patients where HLH is suspected and they're quite ill, we often will start with dex. And then in very sick patients, in very rare cases, we'll also consider empiric etoposide. Additionally, depending on the situation, there may be a role for additional immunosuppressive agents like anakinra, as was done in our patient, that's an IL-1 blocker. Tocilizumab, an IL-6 blocker, can also be used, and also IVIG and rituximab. And then let me just conclude by saying a little bit about hyperferritinemia and HLH. So this is something I learned from Harry Hollander a few years ago. It's that hyperferritinemia that's extreme, greater than 10,000, can certainly be associated with HLH, but the positive predictive value for HLH is low. In other words, there are a bunch of other things that can lead to extreme hyperferritinemia. So this table is from a single center retrospective study at the University of Minnesota, where they looked at 65,000 patients with a ferritin of greater than 10,000. And they found that the bulk of these patients had something besides HLH, most commonly chronic transfusion dependence, liver disease, and a variety of malignancies and infections. So summary, if you see a ferritin greater than 10,000, certainly the differential includes HLH, but it also includes a bunch of other conditions. All right, that's all I've got. Thanks so much again.
Thank you so much, Dr. Lim. I'm going to ask you for that reference. It's great. So I think the message here is don't consult heme or room for a ferritin over 10,000, but do the HLH score, do the H score, and maybe then that's a good consult. All joking aside, just want to give another round of applause for Dr. Sarah Goglin and her masterful clinical reasoning. We really appreciate it. And again, thank you to Viri and Anna for putting the case together. So